Hi, everyone. Welcome to The Relay. I'm your host, Val Emmons. And today we're focusing on one of the most critical challenges in healthcare, how we manage transitions of care across the continuum. I'm joined by Cheri Lattimer, who is the Executive Director of the National Transitions of Care Coalition, which is a leading voice in advancing care coordination and improving patient outcomes nationwide. And today we're going to be diving into the latest State of Transitions of Care report released from based on the DC Summit that was held last September. And we're going to unpack key findings, distant gaps, and what healthcare leaders need to do next. So Cheri, welcome. We just released on April 7th, it was not long ago, this report on critical gaps in healthcare and transitions and calling for urgent policy reform. You want to give listeners an update on that?
I'd be happy to. So, first of all, I think that the general statement that our attendees had at the conference probably says it all with a very pointed statement. Even today, we've made progress in healthcare with transitions. Most of our attendees said they still see care as being fragmented, disconnected, inconsistent across the healthcare settings. I think we may be doing better with transitions within a particular setting, but when the patient and the family move from that setting to the next setting, it still is fairly fragmented and disconnected and inconsistent. And these gaps continue then to put our patients at risk. And especially those that, have chronic illness, behavioral health conditions, complex care needs. And at this very critical junction, when we are transitioning a patient from the hospital to post-acute, from the hospital to home, from post-acute to home, we really need to be able to blend together how we coordinate care and take that as a serious step in improving the patient and family care journey across that healthcare system. So our providers were really clear about that. As the conference went on, and we had about 80 attending, our healthcare leaders were talking about what are the barriers, and they identified several barriers, such as we still, as we all know, have limited interoperability between our healthcare systems, talking about inadequate discharge communication, unclear accountability across care settings, which we've talked about in transitions of care for a long time, and inadequate reimbursement models that really support transitions of care. But I do want to share, Valerie, that they were also very clear. There are just many opportunities for us to really look at how we can improve this by really embracing some of our technology we have today and improving that process, expanding the roles for other clinicians, such as our pharmacists and case managers, and using that care team and not just a single individual to really coordinate transitions of care, to standardize certain aspects, such as our discharge summary, and then to really, and I think this was a key takeaway we took from the conference, we need to coordinate not only policy, but also practice reforms.
So the report, and you and I have talked about this, the report uses words like fragmented, siloed, chaotic to describe transitions of care. Why, after all these years? Because you and I alone have been with you doing this for 15 years at NTOCC. So why, after all these years of focus, why are we still here? Is it system failure or a failure of accountability across the continuum?
Well, I think our systems do fail us. We know that many times we may have a great electronic health record within a hospital system and a large hospital system, but when that patient leaves that system, where and how do we have to communicate with that next level of care? So that interoperability within our own technology is absolutely one of those key areas. I think too that we are still struggling with timely discharge summaries being delivered to that next level of care, if they get there at all. Sometimes they don't. We're still struggling with a care team that may not really know all the various roles and are just looking for the case manager to make sure that this happens okay. And that's not how that can work today. So there's many reasons for that. We have improved. I don't want clinicians listening to this thinking that, well, geez, we haven't done anything in 35 years. Yes, we have. It's gotten better. But patients and families are still slipping through the cracks. We still are seeing adverse outcomes for a poor transition. Communication lies at the bottom of this. And until we can get a handle around that communication and pulling that together. And today we're talking about it not in a written communication, but more in digital, in electronic health records. And until we get that to where it is just seamless when a patient moves from one level of care to the next, we're going to continue to see we have issues in this area.
And so the report highlights, things like unclear accountability as a major issue. So who actually owns the transition today? The name of this podcast is The Relay. And the reason we launched the relay at the summit is because we knew that we were going to be doing this working summit and we knew we were going to be getting this report. And we wanted to have a avenue in which to inform the audience and the industry and all of the people that are involved in healthcare what we need to do to fix it. So, who owns transition for a patient today? Who owns the transition?
Well, no one individual or one clinician or one provider ever owns the transitions of care. When you think how complicated and complex our care system is in the hospital alone and the care that we provide, there's not one individual that provides that care. That care team is significant, all the way down from the hospitalist to the specialist to the nurse, the social worker, the case manager, the physical therapist, the dietitian, the occupational therapist, all these aspects that interact with our patient. So it has to be a care team commitment that the care team is committed to a smooth, safe, quality transition. One of the biggest examples of where we drop the ball is around our discharge summaries. Our discharge summaries, I don't think we've really improved in the content of those discharge summaries in years of what's needed. And yet our patients have become more complex. Our care has become more complex. The clinicians treating the patient have become more complex in the hospital. And so how do we pull a discharge summary that covers all the aspects of hospital care? The discussions that we've had with the patients, the medication, not only reconciliation on admission, but what has been given during the hospitalization. And then what are we sending the patient home with? And all of the aspects of not only their physical and their mental health care, but what social determinants of health are going to affect this. When you start listing out these pieces, that's where we have to start to say, how do we use technology to help us develop a care team, if you will, discharge summary? Yes, led by the physician, but all the various aspects that can be transferred at the moment of transition. We call it the handover of a baton to the next level of care. And we're not going to let go of it until we know the next level of care has that information, understands it, and can act on it. And the patient and the family caregiver have not just been told these are the discharge instructions. They truly understand that. They understand their medications, their illness. And we know that because we've had discussions with them, we've had teachbacks with them, and we are supporting them through that. So when you ask me who is responsible for transitions of care, I'm laying out there, not the doctor, but the care team is responsible for that transitions of care. And our discharge summary needs to reflect that it is a summary of the care received in the hospital by all aspects and going forward to that next level of care.
Yeah, we just did a webinar last week with almost 200 people on that webinar and over this very topic of the report. And you had on one of your slides the comments from one of our attendees, which was, I believe it was, don't throw the baton, hand it off. I thought that was very telling.
Yeah, it is. I think many times we toss out information and even discharge summaries like a football that we're throwing out and hoping someone receives it. That's not what a transition is. A transition is a relay, and it is a baton that has to be handed off and not let go until the next level of care has that baton. That information is critical. And we talk about it a lot, Valerie, just from the hospital, like to post-acute or home. But that information is just as critical for our severely ill patients, chronic care patients, mental health patients, that when they see a specialist from a primary care, that information is seen the same way. It is a baton, handing off information to the specialist with the referral so they can begin immediately to talk and work with the patient. and the specialist sending it back to the primary care so that there's continuity, that there's safety, and that there's quality in those exchanges. And one of the gaps that the participant identified very clearly is yes, we're asking for all of this better communication, handovers, and communication going forward, and making sure that people understand. And yet, we're not really financially reimbursed for that extra work. So we need to remodel how we pay for care and how we pay for transitions of care as we're going forward. And as we talked about during the webinar, we are seeing some of that as we are seeing these new models, access lead guide coming out from CMS, and where we're talking about value-based care and value-based payment in these models. So there, coordination of care, transitions of care is covered under these bundled payments that we have and the assurance of a safe patient journey.
Yeah, like the report emphasized difficulty, like even identifying the right point of contact. That to me is crazy. I don't understand how that's still happening in modern healthcare. You call out inadequate reimbursement for care coordinations. Are we still asking systems to prioritize something that they're not paid to do?
No, we do have codes, but remember that we are moving from, and with guidance from CMS, and we're talking about the Medicare, Medicaid population, our CHIP programs, from being fee for service to really value-based payment. So the codes that we've worked so hard over these last few years to help with
Right.
care coordination, the transitional care management codes, the chronic care management codes, the behavioral health integration codes, all of those are on a fee for service basis. Now those are being wrapped into these new models in a value based payment. So instead of having to bill out a code for every single type of intervention, you now are able to coordinate care and transition care under a value based model to be able to secure good patient outcomes, safe patient outcomes, and quality outcomes.
Yeah, because I feel like the current, you know, payment model, the fee for services, that actually works against safer and better transitions of care. That's just my opinion, but I think the value based care is going to be a lot better positioned to help us have better outcomes, if that makes any sense.
Well, I think many of us feel that you're literally reimbursing for quality, safety, and outcomes rather than just for a quantity of different services that you are providing to a specific individual. So that is the goal of value based payment. And as we move forward with that, we are hoping that the care coordination aspects of that will help us really learn how to not only communicate as a team, but to really provide services as a team. I
I want
think
to
it's
also
also going to cause us, as we heard from many of our participants, beyond the walls of the hospital or the post acute, how do we embrace what's available in the community through our community health workers, our patient advocates, our case managers that are in the community, or even beyond. In some of our rural communities, we are now working with EMS providers to really provide that continuity. So I think these models help us push outside of our comfort zone of, well, I know what I need to do in my box. No, you got to think outside of the box.
well, yeah, and like one of the things that was highlighted as underutilized, one of the positions was pharmacist. And what impact are we missing by not fully integrating pharmacists into that care team?
Well, we lose a huge impact. Our pharmacists, yes, definitely understand our medications and are able to fill those medications, but they are great educators. They also are great coordinators. The pharmacist is usually have an understanding of when a patient says, well, I can't afford that drug. Well, what are some of the mechanisms that can help afford that? Also, a transition of care pharmacist and a community pharmacist have a great interaction with patients and family caregivers. Just not education, but truly understanding what are some of the things that are barriers for them. So incorporating them into the care team for me is not an ask. It's a mandate. We need to have that pharmacist and that case manager and that physician all working together in support of that patient and family care. On top of that, I think pharmacists also provide us a great avenue and journey to truly understand our medications and not just accept them. And so many times just take the medication and the pharmacist will say, do you have any questions? And the patient will say no. And my response to that is, did the patient even know what questions to ask? And I think today our transition of care pharmacists that are focused in community pharmacists go a little bit further to really talk about, now here are some of the things that you need to watch out for, these some symptoms, and you need to call if you see any of these things. So we are getting better at that, but that role for that pharmacist to me is crucial. And I think I've often said the duo team I see is the pharmacist and the case manager, but the triune is the physician, pharmacist, and case manager working together.
Yeah, the pharmacist can actually help you pick which healthcare plan you need on your Medicare by just telling you which medicines are covered under which one. And that's just the tip of the iceberg that they can, things that aren't looked upon. For me, as a non clinical person, I would have never thought to tell my mom that maybe you can ask the community pharmacist which one we should get. Because I just learned recently on an interview that I did, can't remember who it was with, but it was if they get stuck in this one particular Medicare, you're literally stuck and you'll have to pay out of pocket for your medications if you get on the wrong plan. So I think
Yes.
that's a crucial part of a transition. If you're not getting the right medication, that's going to be a big problem.
Well, that's why we say it's so important to truly understand those social determinants, because that financial aspect and your medications that have been prescribed, if you don't have coverage for that, then there's no way you're going to be able to take those or be adherent. Or if you do take them, you're going to be making a choice as a Medicare patient and a senior. Can I put food on the table? Do I pay the electric bill? How do I get my medications? So, and our pharmacists are very good at being able to help us through that process. This is just like what we were talking about earlier. The more that we ask these things to be considered and provided for, the more we have to understand the limited reimbursement we have today and understand what we can glean with these new models and value-based payment. Because we're talking about the whole individual within these models and using the team and being able to provide not only the communication, the treatment options, the care planning, and the follow up, but to be there as their advocate and their mentor and educator.
Yes. So I guess I want to move on to a little bit of AI. The report mentions AI for discharge summaries and risk prediction. Where is this actually ready for real world use?
Well, let's move before we talk about it, let's talk about this interoperability that, and today we have a lot that is moving forward through the direction of both CMS and even at the White House direction of creating a digital ecosystem. And in that is to really take the data and being able to share the data across multiple healthcare systems, multiple health plans, and to be on the same page. We know that many of our organizations are working along this area. NTOCC has been working with the PESIO project and is very excited about the information that we're seeing transferred from the acute care to the post-acute system. And as we see that more and more, all of this information that is being transferred, how can we improve that information with looking at the technology of artificial intelligence? I'll use an example as our discharge summary. How complex the care is at the acute care level and our discharge summary that needs to be delivered to the next level of care. Well, our electronic health records can really help us with that. If we look at where we see the gaps of information that are not being transferred, the electronic health record can help us draw that down and can build that and help us see a much more full discharge summary of content and information that providers on the other end, we talk about handing that baton over, handing the baton and a discharge summary over to that next level of care. And they need to be able to read it, understand it, and move with it. And so AI can help us do that. AI can also help us in other areas of what we're looking at with pre-authorization for care and some of these other aspects. But I always like to say that it does need to have human oversight because we never know just exactly what the data is that's being pulled, and it needs to have a double check.
So what guardrails are needed to ensure that AI supports and not replaces clinical judgment? Like, I know there needs to be a human aspect there, but how do we ensure that?
Well, part of that is to have that human oversight. AI is transforming healthcare in a lot of different ways, from patient monitoring to tracking patient health in real time at home, even looking at some robot assisted surgeries and documentation. So it isn't that we shouldn't use it, it's just we need to have good oversight on how it is used. And we need to be able to feel comfortable. I think many people oftentimes feel, well, I'm not sure I'm comfortable with all the information that I'm getting. But we're seeing some great things. Some of the things that I've just been looking at are follow up calls to patients after a hospitalization from a really, it's not a human being at that point, but it is a digital individual that has been set specifically for that patient to ask the questions, their medications, different things. And then if there is a flag raised, then it's moved to an individual. These things are very helpful. I just think about the number of times in my career that I have tried to reach a patient and have just played phone tag or multiple calls and no response. So I I think we're all looking, how can we use that, but we need to have the oversight and we need to have the understanding of what that is, and really to be able to move it forward. I think some of the things that we're talking about with AI is, let's standardize discharge communication practices through AI. And then let's ensure that patients and family caregivers can get a care plan that is really written and focused in their health literacy compared to what we write around a discharge summary. So I see a lot of opportunity. I just don't want to lose the fact that we need to have human oversight on this as it's being developed. Those are the guardrails to me. We're also seeing that there are some accreditation programs coming out from some of our accreditors, such as URAC and NCQA, that are putting in measures for developing AI programs.
So the report points to opportunities like interdisciplinary models and better tech integration. What's the fastest path to scale these?
Oh my goodness. Well, I don't think you can just say a fastest path to scale models and transition of care models, because each system, unfortunately, is a little bit different. So one model isn't going to take care of all of that. NTOCC believes, and I'm very proud of that, when we created our 7 elements, which was a guide of when you are creating models and transitions are involved in this, consider these 7 interventions, and they are a guide to help developing the program that you would want in your environment and can share with others. And I think that's what we're looking at this particular point, that we have good medication management and coordination, that we have accountability across all care levels for working in a strong program around transitions and care coordination, that we have great patient engagement and education, and family is included in that, that we are looking at follow-up care, a good transition plan, and that we are using what we call the triune, that we are doing a assessment of both clinical, medical, behavioral, including substance use disorder and social determinants of health. And that by pulling those together and creating the models, we're still hitting the 7 key elements that are great gaps and great barriers in transitions of care. And it doesn't matter what the disease state is, because the clinical aspect falls within the support of how we support that patient and family caregiver through the transitions point.
Is there anything that I left out of this report overview that I didn't touch on that is important for our audience and listeners to understand about the state of transitions of care?
Well, I don't want to leave people with the idea that there aren't plenty of opportunities out there for us to be able to work forward and really be able to improve transitions of care. I think one of the greatest steps that we have is working with technology and utilizing it to help us with administrative burdens that we have that can be done with the various programs. I do think that folks need to realize that as we are moving from a fee for service world into value based care models and payment, that there really is this need and this shift to have better communication with our care team within the environment we work in, whether it's acute care or post acute, but then to also improve a communication bridge between that acute care and post acute to home, home to community. And what is it that we can do to make it a safer, and a more quality journey for the patient and the family caregiver through all of this. CMS has got some great models that they are moving forward on. They are also looking at how to move forward with different measurements, which will help support the work that is being done in transitions of care. And I think that for me, it is a great opportunity to be in healthcare today and to be able to move forward with some of these strategies. I just want folks to really remember that it just isn't about talking about transitions of care today. The landscape is such that it is absolutely necessary that we operationalize a safe and quality transition program within all of our facilities across the continuum of care, and that we extend that baton and wait and have someone hold on to that baton with us and share that information. That is a safe and quality transition that can help both patients, family caregivers, and clinicians achieve better outcomes for patients. Val?
I guess that brings us to the end of today's conversation, and a sincere thank you to Cheri Lattimer for walking us through the latest State of Transitions of Care report and the realities facing healthcare systems today. And one thing is clear from the report: transitions of care remain one of the most complex, fragmented, and critical moments in the patient's journey, but they also represent one of the greatest opportunities, as Cheri said, to improve outcomes, to strengthen accountability, and truly connect care across the continuum. As the report reminds us, it's not enough to simply hand off care. We have to pass the baton with intention. Thanks for joining us on the relay. If this conversation resonated with you, share it with colleagues and keep the relay going. We'll see you again next time. Thank you, Cheri.
Thank you.